we're going to be talking about the sex chromosomes and sex chromosome aneuploidies. So here we have the X chromosome, and here we have the Y chromosome. All the other autosomes look exactly the same, but the sex chromosomes, you might say this is a little bit smaller than the X chromosome. The X chromosome is one of the most gene-rich chromosomes that we have. It's up there with chromosome 1. And the Y chromosome primarily has genes that determine male sex. So females have 2 X chromosomes, males have 1. So in order to compensate for the additional genetic material females have, they actually shut off most of, but not all of, but most of one of their X chromosomes. This is a random event. In some cells, the maternal copy of the X is turned off, while in other cells, the paternal copy of the X is turned off. And so here's just an example. In some cells, the dad's copy of the X chromosome is inactive. In other cells, the mom's copy is inactive. The inactive X is determined very early in embryonic development, and every cell that comes from that has the same X inactivated. And this historically was known as the bar body. When they look at under the cells, they'd see this like curmudgeon thing all smushed up, and it's the last chromosome to be replicated during meiosis. So features of X inactivation, as I said, it's a random event, and it involves most, but not all, of the genes on the X chromosome. The inactive X is known as the bar body. It's late replicating and expresses the XIST gene, which is what's involved in inactivation. So here's the XIST gene, and it results in inactivation or methylation, both proximal and distal. Most of the genes on the X chromosome are subject to inactivation, but not all. There are some genes, especially on the short arm, that escape inactivation. And this little black, this is the pseudo-autosomal region. The pseudo-autosomal region is a region at the proximal and distal ends of the X chromosome that have similar genes to the proximal and distal ends of the Y chromosome, which I'm going to talk about at the end of this. So when everybody else is crossing over during during prophase of meiosis 1, the X and the Y hook up together. So translocations involving the X chromosome. We talked about reciprocal translocations and Robertsonian translocations. This is a reciprocal translocation, but a little bit more complicated. So let's just look at this. So because of this X inactivation, in normal situations, either mom's copy of the X is inactivated or dad's, and this is a random event, random inactivation. If I looked at a female and I grabbed tissues from different places, sometimes her mom's copy's on and sometimes her dad's copy's on. If one of the X's is abnormal, there's either deletion on it or extra material from somewhere else, there's actually non-random X inactivation. Nature turns this one off in most of the cells and keeps the good one on. Because, there's an option here. In regular cells, you don't have these options. But what if there's a translocation, a reciprocal translocation between an X chromosome and an autosome? So here's our X. Here's our other X. Well, let's just call this chromosome 1. And then here's chromosome 1 with some X material. Now, if we activate this chromosome, 2 events are going to happen. One is we have some extra X material because we have this plus this, so we have trisomy for part of X. But probably the bigger problem is we have monosomy for some autosome because the inactivation will spread into the autosomal region. So we'll inactivate this whole chromosome, even if this is not X chromosome material. The XIST, it just spreads it all the way down and up. So in order to compensate for that, if an individual has a balanced X autosomal translocation, they actually non-randomly inactivate the normal X. That way, we have the X here and here and the 1 here and here, and we're good. So nature has a way to compensate for this because using X inactivation. Or what if the female inherited let's say her normal X from her dad, and this X, like let's just say mom was a balanced carrier, then the X with part of 1 on it from her mom. Well, in this case, just like over here, we inactivate any abnormal X to allow for compensation. So the next thing I want to move on to is sex chromosome aneuploidy syndromes. So sex chromosome aneuploidy syndromes include Klinefelter syndrome, which is instead of being XY, it's XXY. It occurs in about 1 in 1,000 individuals. Whenever there's an extra X chromosome, we shut off one of them. So we actually can compensate for this extra X. The next is XYY syndrome. XYY syndrome occurs in about 1 in 1,000 males. And the Y chromosome doesn't have a lot of genes on it, so we'll talk about that in a second. Turner syndrome, XY45X, occurs in about 1 in 2,500. But it's actually, so it's the only monosomy that's compatible with life. And then something called a super female, 47XXX, is also about 1 in 1,000. So what are some of the clinical characteristics? Well, Klinefelter's, there are probably some genes on the distal or proximal end of the X chromosome and Y chromosome, these pseudo-autosomal regions, that have to do with height. Because when there's an extra X chromosome, males with Klinefelter's are a little taller than we would expect their genetic height. But they also have infertility because they have lack of sperm. And some have some mild learning deficits as well as ADHD. XYY, they're taller than genetic height, but normal development, normal intelligence, normal fertility, sometimes some behavioral problems. An extra X, again, taller females, some ADHD, mild behavioral problems. And then Turner syndrome, there's only a single X, they actually have short stature. They have infertility, but usually have normal intelligence and rarely have any behavioral problems. So I want to talk about Turner syndrome for a second. It's a complete loss of one of the X chromosomes. This is, again, the only monosomy compatible with life. And so, but it probably happens often as far as conception, because 99% of all 45X conceptions are lost during the pregnancy, are miscarried. They often have a cystic hygroma, which is edema in the entire body, also known as hydrops fetalis. So when they see a very early embryo with hydrops fetalis, this is like number 1 on their list of things it could be. It's, again, the most common cause of first trimester pregnancy loss. 70% of the time, the loss of the X is from non-disjunction of the sperm. Most non-disjunction, Down syndrome, trisomy 18-13 are maternal non-disjunction. This is the only one that's more commonly to be paternal non-disjunction, because dad could either not donate an X or not donate a Y. 30% are because of maternal non-disjunction, because mom did not donate an X into the embryo. So, clinical features include occasionally puffy hands and puffy feet, which they love to ask and stop. And sometimes they have webbing of the neck, and this is probably remnants of a non-lethal cystic hygroma. Some children are diagnosed at birth because of these features, but sometimes they're not diagnosed till age 5 to 6. So features include short stature, webbing of the neck, this kind of widely spaced nipples or a shield chest, widening carrying angles, and then here in the arms. And one of the major heart defects is a congenital heart defect known as coarctation of the aorta. We actually had a baby in the NICU, about a year ago, that from the outside hospital, they were like, oh, we think this kid has Turner syndrome because they have puffy hands and feet. And then the neonatologist said, what's the echo? And they're like, oh, we didn't do one. And he's like, yeah, send the baby right over. And the baby actually had a critical aortic stenosis that had we not put the kid on prostaglandins, probably, and to keep the ductus open, probably would not have survived. So kudos to our NICU staff for recognizing that. So that could actually be a medical emergency for these kids. Klinefelter syndrome, XXY, again, 1 in 1,000 live births. IQ about 10 to 15 points lower than siblings. So if their siblings are at 140, they're still pretty smart. If their siblings are 80, they might have some more problems. Often not diagnosed in the newborn period, although that's changing a little bit with cell-free DNA, because with the cell-free DNA, sometimes we identify males with Klinefelter syndrome, which is actually a good thing, because this is not going to be on your boards, but I'll just tell you this. Testosterone is thought to improve a lot of the cognitive problems as well as infertility. So if it's given in the first 6 months of life. But anyway, so they have tall stature, behavioral problems, post-pubertal small testes. So you wouldn't notice this in a newborn. But if you see a 14-year-old, you might notice that they have small testes. Infertility. But this is also a really important thing, is gynecomastia. Males with Klinefelter syndrome that have breast tissue are at an equal risk to females to develop breast cancer, which we're going to learn about in life cycles. In the aging case too, when we talk about breast cancer, about 1 in 9 risk of developing breast cancer. So equal that of a woman. XYY, about 1 in 1,000. It has to be non-disjunction from the father. So if anybody asks, because this is the only one you're 100% certain, because only the dad gives a Y. So if a kid has XYY, it's usually non-disjunction from meiosis 1 when the chromosomes are separating. Excuse me, meiosis 2 when the chromatids are separating. So if that were a question, you say it's got to be dad if it's XYY. Most of the time you don't know, you couldn't say for certain, but this is one you could. Tall stature for genetic height, IQ, sometimes a little bit lower than siblings. They talk about some behavioral problems, but have normal fertility. When they first started looking at chromosomes, there were a lot of, there were institutions where one floor had kids with Down syndrome. So they drew all their chromosomes. They had a clinical diagnosis of Down syndrome. They said, oh, all these kids have an X chromosome 21. And they'd have other kids, that they would draw and say, oh, they have this. And so they said, why don't we go to prisons and we'll draw a bunch of guys' blood and see if there's a chromosome problem? And they found out that a number of them had XYY. So they wrote a bunch of papers on the sociopathic behavior of XYY. Only they never went to the general population and actually looked what the population risk of XYY was. And so it's actually important when you do a study that you actually know what your population is. And so when you actually look back at the population risk of XYY, individuals in prison are not at increase, do not have a higher risk than the general population of XYY. Again, maybe they're a little taller than genetic height, maybe a little problems in school, but they have normal fertility. I would assume that they would have more boys than girls. But anyway, so the next thing I want to talk about is gonadal dysgenesis. Well, as a rule, XX is a phenotypic female and XY is a phenotypic male. There are exceptions to every rule. That's the code to medicine. The SRY gene is an important gene on the Y chromosome that determines male sex, and if it gets translocated onto the from the Y to the X, it can cause issues. So here we have our pseudo-autosomal regions. Remember, I showed you this earlier, and here's the SRY gene, like literally right next to it. Here are some other important genes on the Y chromosome that have to do with sperm formation. Now, when we have the bipotential gonad, if there's SRY, that bipotential gonad becomes a testes. And if there's not SRY, it becomes, the passive way is an ovary and female external genitalia. There are a lot of other things for male external genitalia having to do with androgens and whatnot, and the testes develop androgens. But if you have an SRY, your bipotential gonad becomes a testes, and if you don't, it becomes an ovary. So, as I said earlier, we have synapses. When all the rest of the chromosomes are exchanging material during meiosis 1, the X and Y do as well. And sometimes So it is, if we cross over normally, we have, our X, and then our Y has the SRY. But what, and this is how it's supposed to happen, but what if it happens a little bit further down? Then we have an X with the SRY and a Y without it. So this individual, if this X is donated, we can get an individual with 2 X chromosomes, but the SRY. And they could have either a male phenotype or what we call ambiguous genitalia. This is because the SRY is what's determined if the bipotential gonad becomes a testes. On the flip side, what if the dad donates the Y that has a deletion of the SRY gene? And this is an XY female. They have an X chromosome. This is actually the opposite fish that I should be showing. The X chromosome and an SRY. And actually, if I did fish, there would not be an SRY region there. So I'm going to move this. So ignore this. This was actually probably should be in the previous slide. So that, so I'm going to just move this to the previous slide. So when I make your slides, they will be in the right place. So this is what the fish would look like in this patient here. We would have 2 X chromosomes in the SRY region. And if I did fish for this, all I'd see is 1 X, and the SRY region would not be there. So that concludes this lecture on sex chromosomes.